By the way, my name is Jody Crane. I'm a faculty member for the Institute for Healthcare Improvement. I'm a practicing emergency physician in the United States, and I've been an ER doc for about 11 or 12 years. And I've practiced in a very busy emergency department, as I'll show you in just a minute. In 2008, we saw over 108,000 visits per year, so a fairly busy place. I'm also on a faculty member in the College of Business at the University of Tennessee. So I teach physicians about healthcare operations in their Physician Executive MBA program. So a lot of the stuff that I'm going to talk to you about is about improving EDs, and it's I'm going to teach you a little bit about the academic framework, and then kind of rapidly go into best practices, and hopefully show you some fun things as well. So the keys, the objectives here are to identify the key challenges and barriers to efficient patient flow in operations, and understand these key important improvement strategies. I want you guys to be able to kind of take this information and just go home and do some quick things, maybe some things you can do tomorrow, next week, but then also think about how you're going to run your emergency departments long term. And then finally, I want you to understand that there are some important change topics, and to understand the role of leadership and change management in the way we run emergency departments, and what we're going to be doing in the future. So this is a newspaper article, and I know you can't read it, but I'll read it for you. This is from an emergency department in the United States in one of our states called Arizona, a city called Tucson. And we have problems with overcrowding in our emergency departments. We have too many patients that we can handle. This was a 39-year-old guy who showed up to the emergency room, was waiting in the waiting room with his wife. They got there around 6:30 at night. By about 2 o'clock in the morning, he was finally seen. He showed up with a fever. And by 2 o'clock in the morning, he was seen and treated in the emergency room. And shortly after arriving they eventually put him in a critical care bed. Shortly after arriving, he coded and died. So he was waiting in the waiting room for about 8 hours and died from a virulent strain of pneumonia. He had methicillin-resistant staph pneumonia. So he died. And that death was completely preventable. If this ED had been running their ED properly and effectively using the latest techniques, this person would have still been alive. And there's many cases like that in the United States and Canada, all over the world. You can read about it. This is just a little bit of my background. So again, I've been working on ED improvement for about 10 years, and in my own emergency department for the last 7 or 8 years, our volume has gone up about 6 to 10% per year. So we've been working very heavily. We haven't added a single room since 2002. So we've grown our volume by over 50%. We've reduced our walkout rate from a high of 13% down to around 1% now. The way we've been able to do that is focusing on performance improvement and driving down our length of stay. Before 2004, we didn't even measure our length of stay, but it was somewhere in the 5 to 6 hour range. In 2004, it was right around 4 hours. And over this particular 6-year period, we dropped our length of stay from about 4 hours down to about 2.5 hours. And as you guys know, if any of you guys are into performance improvement, reducing length of stay is equivalent to adding beds for free. As a matter of fact, if you go back to this graph, from 2004 to 2007, we really didn't change the number of doctors we have in our group. We didn't change the number of staffing hours or the number of shifts. We basically focused on performance improvement and focused on optimizing the resources we have. Some of the tips I'm going to give you today are going to be about how to optimize your resources. This is our patient satisfaction graph. And back in 2004, we were the worst. We were the worst out of the large EDs that measure their patient satisfaction. Matter of fact, we could have gotten up to about here, which we did, and we were still the worst. So we were kind of magnitudes of bad. But over the course of, and our patient satisfaction now is way up here. But we never really kind of consciously focused on patient satisfaction. We focused on doing the right thing for the patient. And we focused on teaching our staff and optimizing our emergency department operations in the way it works. So we've got kind of 3 topics we're going to cover. The first is the academic principles, and then we're going to look at the flow and the intervals in the emergency department. Then we're going to talk just briefly about change management. So it's a tall order for 60 minutes here. The first big topic I want to talk about is something called queuing theory. Have you ever heard of queuing theory? Okay, good. So 5 years ago I asked that question. Nobody in the room raised their hand. Almost everywhere I went. Now it's about 10 to 20, sometimes 30% of the room. Queuing theory in a nutshell, and I don't, the whole, to teach you guys in order to be masters of queuing theory, I'd probably need about 2 hours, but I'm going to do it in about 5 minutes here. So queuing theory is basically the study of why lines form. The queue is a line. You've got a server, you've got some sort of arrivals, and then you've got departures. Now it turns out if we know the servers in the system and their ability to treat, so in other words, how many patients can a doctor see per hour, how many patients can a nurse see per hour, and then how many patients are coming in, we can understand a lot about the system. It turns out if we know that information, so the service rate of our key servers and the arrival rate of our patients, literally by hour of day and by day of week, we can actually predict how the system's going to perform. We can calculate things like how long our patients can be waiting. We can calculate things like how many patients are going to be in the waiting room. We can calculate how many patients are going to be in the system, and we can calculate how long are they going to be there. And it's real interesting because most people kind of, when they staff their emergency departments, they just say, well, I kind of feel like we need some more nurses here. We need some more docs here. Usually that method is a lagging method, or in other words, it chases the wait. So you end up providing staffing downstream of where the bottleneck occurred or where the problem occurred. So here's a simple problem. So we've got an ED with 4 patient arrivals per hour, and it takes the nurse 12 minutes on average to triage the patient, or about 5 patients per hour. Now, the average onlooker would say, yeah, that triage system's probably going to work pretty well. But it turns out you need to know some more information about this. You need to know how much variation there is in the system. You have to know what tasks the people are doing and the different demands from the patients and the different ways that your servers or your nurses or your docs treat those patients. But it turns out, if you look at this, you could kind of look at a system and say, well, there's times when the system will have no waiting because no patients will show up. And there'll be other times in the system there'll be long waits. And it turns out there is a configuration of this system that will have no waiting at all ever. And that version of this is a system that has no variation. So in other words, if the arrivals came every 15 minutes and the nurse service time only took 12 minutes and took exactly 12 minutes each time, we'd have no waiting in the system. And I'm going to show you just for efficiency perspective, I'm going to show you what this looks like. I've got a simulation model here, and I've geared this simulation model to process basically 4 patient arrivals per hour, and the nurse can treat 5 patient arrivals per hour. And I'm just going to step through this, and when I press this button, it's just bringing another arrival. So the patient's arriving, he's arriving every 15 minutes, the nurse is spending 12 minutes with the patient, and they're going home. As you can see, the waiting room's never even needed. And I can speed this up to really, really fast, and I can process it over a day. And we can see this continuous cycle here where we never have more than 1 patient being triaged. And they're always coming, going. Nobody ever in the waiting room. Length of stay is 12 minutes. That's exactly how long it takes the nurse to triage the patient. Now, that's kind of an easy one. But what if I do this? What if I simply inject some variation here? And all I'm going to do here is I'm going to take into consideration that patients don't arrive exactly every 15 minutes, and the nurse doesn't spend exactly 12 minutes with each patient, but the nurse has to do this and that, and take a long list of meds on some patient and a small list of meds on other patients, and patients want to tell their life story, and other patients just want to get in and out. And I'm going to reflect the fact that sometimes a busload of patients drops in, but it's truly in a random fashion. And we're going to see how this system works. And again, this is the only thing I've done. It's still 4 patients per hour. And it's notice that the utilization of that nurse was 80% in the prior model. And again, this is a similar model, which is arrival rate of 4 per hour and service rate of 5 per hour. Now I'm stepping through, and this particular nurse is with this patient here. And now a patient arrives, and the patient's spending time with the nurse. So the patient has to hit the waiting room. Another one has to hit the waiting room. You go on some more, and maybe a couple patients have to hit the waiting room at some point. And again, if we speed up, so in this particular snapshot, we've got one patient being triaged and 2 people in the waiting room. And if we speed up this model again and run it over 24 hours, we're going to see that, at this one point, there was almost 6 patients in the waiting room. And you just watch the waiting room kind of fill up. And on average, there's 1 or 2 or maybe 3. This line here is 2, this is 4, this is 6. Wow, at that time, about 8 patients. We had a case where there was a bunch of arrivals, and then the nurse spent a lot of time with that one patient. But on average, we're kind of running about, 2 or 3 patients in the waiting, or kind of in the system at any given point in time. But let's let this run for another day. So we're running it for a day here. And this day looks pretty good. The average length of stay was 22 minutes. And I'm actually kind of doing this cumulatively as well. So it looks like this is a same arrival rate, same triage rate, just a different pattern of patients. So it looks like the nurse got really backed up at one point and working down the queue again, and so forth. And we can go on and on with that. Looks like the average length of stay on that day is 49. So in other words, the same configuration, same parameters, but we've got a different pattern just due to the way they arrive and how long the nurse is spending with the patient. And hold on to that thought, because notice the nurse utilization is still at 80% here. Still 80% utilization. Still spending 12 minutes out of every 15 minutes working on the patient. So let's do one thing. Let's increase our arrival rate. So the problem with queuing, when you study queuing, and the reason why EDs sometimes don't work that well, is because small fluctuations in volume and small fluctuations in demand on providers will cause your wait times to go through the roof. And so all I've done here is I've changed the arrival rate. I've left the variation. I've left maximum variation on the nurse side, maximum variation on the physician side, and I've increased the arrival rate from 4 patients per hour to 4.6 patients per hour. So in other words, the nurse is spending 12 minutes with each patient, but a patient's coming in every 13 minutes instead of every 15 minutes. Let's see what happens to this one. And I've got it kind of already in high speed mode here, just for efficiency perspective. So all of a sudden we're kind of stacking up more frequently and more often. And again, we might have good periods, we might have bad periods. And this is day 1 here. And I'm using, again, it's a random arrival, but it's the same pattern that I used before, the same distribution, but just higher frequency. So in other words, we had 2 periods where we had like more than 8 or 9 patients in the waiting room. And it looks like our length of stay is kind of pushing out to about 30 minutes. And again, this is day 1. And again, this is the same average arrivals every hour of the day. It's not kind of going up and down as ER arrivals go. But now look at, there might be periods where the ER really gets overwhelmed. As a matter of fact, we got now, the whole waiting room is filled up and patients are actually waiting to get in. So we actually had a period where there was 15 patients that were all trying to jam up into the system. So notice the utilization of the nurse here is it's 80 here, but in actuality, if you do the math on it, it's going to end up being closer to 92%. So it's going to push up here, and at a steady state, the nurse will be at a 92% utilization. So, and the problem with this is that we've kind of pushed the utilization of the nurse too high, and that's causing waiting, just by adding slightly more arrivals per unit of time. And then the last one I'm going to show you here is, again, this is kind of a mess with just a small increment of 15% increase in the arrival rate. But the interesting thing here is if I again take that same system and I eliminate the variation. And again, it's not possible to eliminate variation in the emergency department. But it is possible to improve variation. I'll talk to you about that in a minute. But it turns out, if we simply eliminate all of the variation in that same exact system, again, we're going to have no waiting. So we have no waiting because the patient's coming up every time at the exact same time, and their arrival rate is less than the service rate of the provider that's taking care of them. This is a very important concept, this variation, and this fact that as we push on utilization in systems with high degrees of variation, we're going to get in trouble fast. And the relationship is an exponential one. So it turns out in systems like emergency departments where we're pushing on our doctor utilizations and our nurse utilizations and the utilization of the lab and radiology, our wait times are going to go up exponentially. So the busier we get, the wait times go through the roof. Now in the emergency department, patients don't back up out the door like that. They just kind of drive by and they say, I'm not going there. So they're going to balk at some period of time. But probably most of you guys are experiencing pretty booked waiting rooms and pretty long waits for care. Same thing with variation. As variation increases, wait times go up in that same distribution. So the key to managing emergency departments is actually understanding and building in capacity buffers for this variation the variation arrivals, or trying to smooth the arrivals. And then the solution on the provider side is try to eliminate variation at all costs. Standardization. And when I talk to doctors about standardization, they kind of get this like evil look on their face, like I'm the devil. But really the truth is I'm not talking about affecting the way you practice clinical medicine necessarily. I do think you should standardize clinical medicine, but just get rid of the waste. Get rid of the things that you don't need to do. Get rid of the searching for supplies and all of that. And I'm going to show you what I mean in just a second. How do we build reliable systems with low variation? I use Lean as my performance improvement methodology. That's one option. All I care about is that you have a systematic approach to performance improvement. I like Lean because it focuses on the patient and focuses on delivering value and eliminating waste. It turns out if you all go home and the only thing you do is focus on reducing waste in your system. So if you focus on reducing waste in your system, then it turns out you will do a great deal to reduce your variation and you'll provide more reliable healthcare systems. So it's about adding value, creating value for your patients, eliminating waste, and promoting flow. And the only way you can promote flow is to understand that queuing theory and understand how handoffs and exchanges occur in your emergency department. And then Lean's about creating this environment of continuous improvement. So it's about really kind of getting your ED to the point where good is not enough. We have to continuously improve. So these are the forms of waste. And it turns out if you just look at these in your ED, and I'll highlight the big ones in the emergency department are over-processing. So 3 or 4 people asking the same questions to the patient over and over again. It's doing too much information collection and triage, for instance. Most of the triage scales in the world have just a few items that you need to really address. You don't need to put all of this information, medication reconciliation. You don't have to collect, who's your next of kin and what's your DNR status. You just need to know, are you sick or are you not sick? And you need to know what does a doctor absolutely need in order to treat this patient. So over-processing is a big one. Waiting occurs in almost every ED I've ever seen, in any country I've seen. Movement is a big one. And I frequently see this in big, giant EDs. And when organizations come to me and they say, hey, would you help us with our new ED design? I say, well, yeah, the first thing I want you to do is cut it in half. Because big EDs don't work. The bigger the ED, the worse the communication, the further the walking, everything gets bad in large EDs. You can process very efficiently high volumes of patients through smaller footprints, and that's a key point in terms of, but those are kind of the biggies there in emergency medicine. And then rework or defects, and those show their heads in a number of ways. So there's tools that are used in Lean, and again, these are tools to help you improve your emergency department. The value stream mapping, standard work. I actually believe that standard work analysis, or understanding your demand coming through the door and your capacity to treat that, is the most important thing in emergency medicine. And I'll tell you about some of the other kind of things that I think are really, really important as well. These are just tools, and they're tools that you need to apply. So I'll give you some reading references at the end of this. Look them up if you want to learn more about Lean tools. The next thing we're going to talk about is improving flow in the emergency department. We're going to take the classic intervals. So the door to the doctor seeing the patient till the time that the patient is dispositioned, or whether they decide they're going home or being admitted, and then from the disposition to the departure. And actually what I'm going to do is I'm going to flip that backwards, because I actually think the most important interval in the ED is the back end. It's the most broken interval in most EDs. Boarding in emergency departments. So we've all got problems in boarding, and probably the most well publicized are US, Australia, UK, and Canada, but I know they occur everywhere. So the back end is critically important. How do you approach the back end? First thing you have to understand is what's the utilization of your inpatient areas. So first thing you have to know is there no room in your hospital, or do you have a process-related issue? And sometimes you have both. Sometimes you have room in the hospital, but they're just not staffed rooms. It's important to understand this, because if your hospital's full, you can work on the process all you want, you're not going anywhere. So it's really kind of important here. In the US, we are kind of moving towards disposition to departure upstairs in the hospital of 1 hour as a goal metric. We've been at 2 hours for a long time. Lots of EDs hit it, lots of EDs don't. And it all depends on kind of what's going on upstairs. It turns out when this utilization rate, this is just census divided by your number of staffed beds, when that number hits 85%, you start to have queuing. Just like I showed you in that little simulation there. But you get queuing, and queuing in the hospital ends up where? In the emergency department, right? So when inpatient wards start to exceed 85% utilization of all beds, then you start to have boarding in the emergency department. And this is just an example of boarding. This is from a hospital an ED in the United States that sees about 90,000 visits. And this is literally the average boarding in the ED by hour of day and by day of week. So this is one whole week. The blue represents average, and that's 15 there. And the red represents 75th percentile, and green represents 95th percentile. So imagine this ED probably looks very different when they have 15 boarders on an average day versus when they have 26 boarders on a pretty bad day. So how do you handle 26 boarders? Same thing, here's ICU. Why is it important to understand the difference between non-ICU and ICU boarders? Because they require different resources. Both boarders pull nurses away from patient care, and that's kind of the critical thing. We can do okay without beds, but we can't do okay without nurses. It turns out if you know this information, you can actually figure out how many nurses you're losing. So if you understand how many ICU holds you have by hour of day, and how many nurses it takes to staff them, and how many non-ICU holds you have by hour of day, and how many nurses it takes to staff them, you can actually calculate how many what we call FTEs, or full-time equivalents, or full-time staff members you're short. In this particular case, this is a pretty bad boarding emergency department. It was 12 full-time nurses that were providing care for other patients other than emergency department patients. And this is really important, because if you only got 60, 25% of your staff is doing something else. That means you can't care for your patients. And again, that's higher utilization of the nurses that are remaining. So if you do have a back-end problem, and it's a problem with bed capacity, first thing you have to do is understand how you're staffing those boarders. So what I just showed you. The next thing you have to understand is where are the high target or high volume areas within the hospital? Because it turns out your solution is not going to be in the emergency department. It's going to be in the wards. It's going to be in the ICU. It's going to be in cardiac telemetry or monitored areas. And you may have a symptomatic queue for the ICU in terms of you may have lots of ICU boarders in your emergency department. And you may go, oh, the ICU is really bad here. But it turns out the ICU might not be able to get patients to telemetry. So patients are bogging down ICU. So it's really important to kind of understand what's going on upstairs. And observation units are great alternatives. Observation units are short stay units that have very algorithmic care models. So chest pain, TIAs or kind of rule out stroke, asthma, COPD, CHF. Get them all on pathways. Eliminate all the consultations. Just get one provider to care for these patients in a pathway-driven way, and that reduces variation and streamlines patient throughput. That gets patients into the hospital better and out of the hospital better, therefore it offloads the ED from boarding. Working on the admitting and discharge process. So there's actually some great posters out there, by the way, really good. There's one from the UK, there's one from Singapore, there's one from Ontario that kind of highlights some of these best practices. But working on the admitting process, something as simple as making sure the patient has a ride for their discharge the next day can impact ED flow. Some big things that are occurring in the U.S. is something called the full capacity protocol by a guy named Peter Vicellio. And this is basically taking all the boarders out of the ED and just putting one on every ward, right in the hallway. And it's starting to gain some popularity, and you wouldn't think so because there's been a lot of resistance. Turns out when you start to move towards that model, it basically makes the line visible upstairs and makes the people upstairs start to get creative about discharging patients in a timely manner. And then Eugene Litzbach's from the IHI, OR smoothing. So it turns out the OR is intimately associated with ED crowding or hospital overcrowding. So it turns out in the beginning of the week, everybody's trying to find a bed. And it turns out of all the patients trying to find beds, the OR is actually scheduled. They're scheduling competition for your ED beds. So what Eugene Litvak says is, hey, let's just smooth out the demand over the entire week. And this is one of these things that's kind of easier said than done because EDs or hospitals function like great from Monday to Friday, but very poorly Saturday and Sunday. So in order to execute on this, you have to actually make your hospital a 7-day-a-week operation. You have to provide all the services, physical therapy, rehab, case management, and everything on the weekends. And then one countermeasure I think is most important is developing a hospital-wide patient flow team, led by somebody high up in your organization that has dashboard-driven metrics so that you have a clear understanding of where your targets are, and you have all of the people in the hospital targeting ED patients and ED throughput. It's a whole mindset of your organization to say, we're not going to let patients hang out in the ED. We're going to get them upstairs. The next thing we're going to talk about is our doc to disposition issues. So we're going back into the ED now, and we're saying, what do you need to do, or what are the key issues within that time when the patient's in the department? And it's about aligning your resources, looking at your inventory system, and then optimizing provider productivity. So this is actually from an ED in Brazil. And this is just to show you how important this capacity alignment is. And you might not be able to see it too well. This is the number of arrivals or capacity. And each of these lines represents a resource or a patient arrival. So blue represents patient arrivals by hour of day. And as you can see, at about 9, 10, 11 o'clock, their peak arrivals are 6 patients per hour. However, when you translate the number of staff members they have on duty into patient capacity, so it's how many they have on times how many they can treat per hour, their nurses actually can treat about a little over 4 patients an hour in the overnight, and then a little under 3 patients an hour during peak time. So the nursing capacity is dropping right at the time when the arrivals are occurring. They're at their peak. The doctors are going up, but not enough to accommodate the demand. So, in other words, every single day in this emergency department, they're going to have predictable waiting that's designed systematically. It's built into their system, and it's going to occur every day unless they do something differently. So, another way to look at this is blue is beds per nurse, red is beds per physician, and green is nurses per physician. Now, in an ideal world, these lines are flat across the whole entire 24-hour period. So in other words, as your patient arrivals bump up, your docs bump up, your docs increase, your nurses increase, and your beds increase in perfect ratio with your patient demand. And what will happen is you'll maintain a consistent ratio of docs to nurses, nurses to beds, and docs to beds. Now, the problem with this is anywhere you've got a fluctuation there. So if you've got a period in the day where you've got 5 nurses on and 1 doc, and you've got another period of the day where you've got 2 nurses on and 1 doc, you've lost some resources. Chances are at the 5 nurse staffing ratio, you've got wasted nursing resources. And chances are on the 2 nurse staffing ratio, you don't have enough nurses to care for your patients, so you're building up queues. And I'll show you kind of a really dramatic example of that. This is another just straightforward. So if you just take your arrivals and you translate that into demand for nurses. So this is our arrivals by hour of day. And this curve is the same all around the world. I've never seen a curve different except very specialized EDs like pediatric emergency departments and some very kind of regionalized differences. But it turns out if I translate that arrival pattern into demand for nurses, and then I overlay my nurses, I can see where this particular ED is going to get in trouble. Just a different way to look at it. But it turns out I've got a lot of excess capacity in the overnight, and I need some capacity right at peak times, but I'm never going to work down this queue that forms between about 8 in the morning and about 5 at night. So all I do is I realign. I haven't added any resources, I've just dropped the night resources and I've shifted them to the daytime. Again, now I've eliminated the queue when it started, and I'm going to have a much higher functional, much more highly functioning emergency department, and I'm going to have predictable performance now, and a little capacity throughout the entire afternoon. This is a real case study, actually, a hospital that we're working on right now. Had a real bad boarding problem. Again, 90,000 visit ED using 91 beds, 91 emergency department beds. Significant boarding problem. 20% difference between the weekday and weekend volume, but flat staffing, the same exact staffing by hour of day and day of week. And this is the norm. Like if I took 100 ERs, 80% of them would have this, except the most enlightened ones. So what we did is we just realigned the staffing by day of week, and we found that they were wasting about 3 nurses, or in the US about $228,000. And then we realigned the nursing by hour of day, by day of week. So this was their baseline, the baseline that they used every day. So at 3 p.m. they had 18 nurses on. But, and then this is what we recommended, and we basically just aligned their staffing to when their demand said they needed it. Here's the times they got it right in yellow. So every time you see a yellow box, that's when their current staffing matched up exactly with what the data says it should be. So 90% of the time they were staffing their emergency department wrong. What did that translate into? 9 FTEs, or 9 nurses, were wasted in their schedule. 9. That translated, and this is actually an underestimate, but it's about $1 million in wasted nursing staff. So in other words, there were periods of the day where they had way too many. It turns out on the weekend they had about 4 or 5 too many nurses. And on Mondays they were short about 4 or 5. So what this basically color-coded chart represents, if it's dark, it means nurses were moved away from there. And if it's light, it means nurses were moved towards there. So in other words, we shifted nurses from the nights and weekends towards the middle of the day and Mondays, Tuesdays. shifted them to when their demand truly said they needed it. And I'll show you another view of this. This is another view, and this is of the whole week. This is the whole week, and these bars are just the different layers of demand. This incorporates holding, boarding, arrivals, everything. And so the black was their baseline staffing, and the green is just what we realigned it to. Again, we didn't add a single resource, but their ED is going to perform a heck of a lot better. It's going to perform very, very well once they implement this schedule. So the next important thing within the walls of the ED is to make sure that you have your inventory and supplies where you need them. Don't make people run all over the department searching for supplies and searching for inventory and searching for things they need to interview patients. This is a project that we did in my ED. We just took everything out of the room and we put back exactly what we needed to care for the patients. So we had just basic supplies before, but we ended up with saline and IV tubing and blood vials and everything you needed to treat a patient. And the difference was we just had to have a locked cabinet instead of a non-locked one. So in other words, now when we're treating patients in my emergency department, I say, hey ma'am, you look kind of dehydrated. We're going to start some fluids on you. Instead of the nurse running right out of the room, she just opens up the bedside server and starts the IV and gets things started. I mean, it kind of seems stupid when you think about it. Like, how did we ever get to the point where we didn't have the stuff there? And you think about waste, and you think about finances, and you think about money, and how are we going to charge for things. But it turns out it's the most important, the most expensive resource you have in your emergency department is your human resources. Why not support them and make them as efficient as possible? We're not going to be growing any more nurses or any more doctors. But patient demand is going to continually go up. So we need to make sure we get it right. This was just a spaghetti diagram. It's a map where we were literally in this room and we just mapped where we went to get all these supplies. It was real enlightening. When you do this with your staff, it's very enlightening because they go, okay, wow, why do I run all the way over there to get that? Why do I have to run all the way across the ED to get something that costs 50 cents? It's looking at your trays that you treat, your surgical trays, making sure you only have the stuff that you need. No waste. Lean inventory is waste. Supplies, too many supplies are waste. It's about having reliable locations for your equipment. This is called footprinting. So if you go back to your ED tomorrow and you say, I'm just going to make sure there's a space for everything, and everything's in that space. And then your staff members realize the value of putting things back. And they can put them back because it says right on the machine, return it to this location. It's spending an extra minute so you don't have to search for 5 to 10 minutes for that item. This is, and carts, putting supplies in carts so you have exactly what you need. So if a patient has a specialized condition, you don't have to wait for that room to open up. You wheel the cart right in there. Again, these are straightforward things that you can go back and do tomorrow. And the last big topic on the doc to on the NED interval is the doc and nurse productivity. So productivity can be tough. It can be misleading. In the U.S., our doctors usually kind of produce in the around the 1.8 to 2.2 patients per hour range. Some are much lower. I've seen EDs in the 1.4 patients per hour. I've seen EDs in the 2.5 patients per hour. Nurses traditionally in the 0.5 to 0.8 patients per hour range. Now, benchmarking can be misleading, so I would just kind of take this for what it's worth. But it's important to understand how many patients per hour your doctors can see and how many patients per hour your nurses can see, because that drives everything. That's the whole queuing equation. You got your arrivals and you know how many people you have on and you know how many people they can see, each person. So that's the equation. It's math. I mean, we're all scientists, but we've only been taught to master medicine. We need to be taught how to master operations, because it's all the same stuff. It's math. It's addition, subtraction, multiplication, division. That's it. So, and this is a special problem with countries that are evolving. So if emergency medicine hasn't been around for decades, then you're actually facing some very tough challenges. Because not every ER doc is an ER doc, right? You've got surgeons, You've got internal medicine, you've got pediatrics, you've got OBGYN, and all those doctors are kind of sitting there going, okay, where's my patient? You know, the surgeon could be, you know, have too many lacerations while the internal medicine person is kind of sitting there going, where are my patients? And vice versa. The surgeon can be idle when the internal medicine's full of a bunch of earaches. The key to solving this problem is education and understanding, like there's 3 buckets of patients. There's easy patients, there's difficult patients, and there's the patients in between. And every person practicing in every emergency department, regardless of your specialty, should be able to treat every kind of easy patient. That's pooling. That allows you to maximize the utilization of your resources. Every ER physician or every physician practicing in an emergency department should eventually be very competent at the difficult patients. And then those ones in between are the ones you take a career to figure out. And I'm still learning as well. I mean, it's 12 years later, you're still trying to figure out how to handle those patients. But the key is fewer consultations, fewer decreased length of stay, and more efficient utilization of your resources. So, teams. I've seen lots of EDs that are in these giant, huge emergency departments, and doctors are running all over the place, and nurses are running all over the place. Matter of fact, in this 90-bed emergency department, no doctor bed assignments and no nurse bed assignments. So that is, you know, when we talk about waste, the movement is wasteful, just running all over the emergency department. But then imagine you might have 10 patients and you've got to find 10 different nurses to get an update on those patients. Or the nurse might have to find 5 different doctors to kind of understand what needs to happen to that patient. Imagine if you just had 3 nurses and 1 doctor, and all those nurses knew how that doctor practiced, and that doctor knew exactly who their nurses were, and every so often the doctor would say, hey, let's figure out what's going on in the patients. And they would just do a round. Everybody gets into a group, boom, talk about all your patients. That's efficiency, and that's why teams help. Scribes. Scribes, this is an evolving phenomenon, and it's scribes are kind of assistants to the doctor that go around and they transcribe what happens. So they write down the history for you and they type it in the computer. This is really big in the US right now because we're all going to electronic medical records. Probably in the last 5 to 10 years, we've had this massive swing from paper to electronic medical records, and it's causing a lot of productivity issues. So I wouldn't say it's causing them, but the changeover has been challenging, let's put it that way. But so we have scribes type the information in the computer for us. They can do all kinds of really creative things. And again, this is a way to offload your doctor. If your doctor is overutilized or you need really, really high productivities out of your doctor, this is a way to get that charting out of your doctor's hands. Understanding your nursing breaks, and same goes true to nurses. You need to find ways to offload your nurses. But nursing breaks in particular are kind of bad. Docs don't necessarily go on the break all the time, but it turns out in almost every ED I've seen, there's this scheduled lunch break from about 11 in the afternoon till about 1 or 2. And it turns out if you've got 3 of them, that means 33% of your staff are on break at each hour during the highest volume hours in your entire emergency department. So from 11 to 2. Highest volume you're going to have in the entire day, and you're dealing with it with only 2/3 of the resources you thought you had. So it's really important to understand this and make sure that when nurses go on break, they're covered. Because you can't cover a whole nother team. If your nurse ratios are 4 to 1 and a nurse goes on to break, how in the heck are you going to cover 8 beds? You're not. If you can, then why isn't every nurse covering 8 beds? It's not possible. So, point of care testing. This has got a lot of promise. I would say it's not there yet. The problem with point of care testing is, what if your nurses are really your bottleneck? Well, now you brought all this fancy equipment into your ED, and now all your nurses are spending all their time in front of this equipment, and your actual length of stay is getting worse. However, if you do have problems with ancillary turnaround times, then these can be a huge benefit for you. The most intriguing one that's come out recently is right from this part of the world, Denmark, Chempac, and that's a CBC. Why that is a game changer is because it has a white blood cell count and a differential. When you order blood work, 8 out of 10 times you're looking for that white count. You need the CBC, or you need the hemoglobin, hematocrit, you need the electrolytes, but there's very few patients, it turns out, that you can treat with just electrolytes and just an H&H, or hemoglobin and hematocrit. So make sure you understand that, and don't just sort of pull the trigger, or don't just go, I'm going to get point of care test, because there really has to be a well-defined method for what you're going to use it for. And then last, and probably my area of interest that interests me most, is the door-to-doc. So how do you get patients in the front door? The first thing is to understand what's causing your queue. We talked about this. It could be boarding in the emergency department, could be inefficiency within the walls of the emergency department, but it might just be your front-end process. And it turns out in the US there's been this push for at least the last 10 to 15 years on door-to-doc in 30 minutes. And it turns out that's the gold standard in the US, is door-to-doc in 30 minutes. And it's a good goal because I think it emphasizes the right thing. If you get your patients in front of doctors in a timely manner, that means they're more likely to be stabilized and they're going to go home more quickly. So you want the level 1s and 2s, the high acuity patients. You need them to get in front of docs so they can be stabilized. You need the low acuity patients in front of a doc because that's the only thing keeping them from going home. So if your patients are waiting out in the waiting room for 10 hours and all they need is a script or someone to look in their mouth and tell them it's a virus, then you need to get them in front of docs. And then the level 3 patients, the reason they need to see a doc is because testing is going to be their real kind of thing that's going to keep them in the emergency department. So you want to get those tests started, you want to get the treatment started, and then you want to find that 1 in 100 level 3 patients that's going to have a problem in your waiting room. You want to find that patient that shows up with a fever that if they wait for 8 hours, they're going to die. It's usually chest pain, fever, abdominal pain that really tend to have problems and tend to die in waiting rooms. So you need to get those patients in front of docs. Not only is it more efficient, but it's safer. It's better quality. It's getting patients in front of docs allows you to implement these bundles. There's a nice poster presentation out there about implementation of a sepsis bundle. And the first thing for sepsis is identification. The quicker you identify them, the better your quality is going to be. The quicker you get that bundle started. Here are just a few options, and there's some really great work going on. I encourage you guys to do a lit search on it, and I'll give you some references again. So direct pullback is just putting patients right into a bed, skipping triage altogether when there's a bed available. That's a great strategy if you have endless numbers of beds. But sometimes ERs that try this, they end up just kind of filling up their beds by 11 o'clock every morning. And so most EDs that I go to are full by 11. So my sort of strategy is really kind of look at the patients that need beds and look at the patients that don't need beds. Look at the ones you could treat as an outpatient. Triage protocols are okay, but they're wasteful because they're relying on one person to predict what another person's going to do. And it's not because it's a nurse and a doctor. It could be a doctor and a doctor. It could be a doctor and a nurse. The point is, triage protocols do not replace a physician evaluation. Having a mid-level, and I realize most countries don't have what we call mid-levels, or they're like physician assistants, so they can do kind of a lot of the work that a doctor can do, but they have to do it under direct doctor supervision. We have mid-levels right in our triage, so we've actually replaced some of our nurses in triage with mid-levels so that they can treat and release patients and send them right back home. Physician and triage are really attractive models, and again, it gets the patient in front of the doctor immediately so that they're not waiting on nothing. They're waiting on test results to come back. So it gets that clock started that moves the patient closer to being home. This is one example of a model that's in Pennsylvania. It's a little town called York, Pennsylvania. But this ED redesigned their ED so that these 3 rooms The triage waiting room is right here. It's completely open right to the waiting room. And the doc just pops between room to room to room, grabs patients out of triage, assesses them, and sends them home. Really efficient. And again, in the lean sense, it's just eliminating all of that waste. It's eliminating all those things that come between the patient and the doctor. This is my shop. This is my hospital in Virginia. And we have a similar model, but because we're so busy, we need lots of docs and lots of nurses up front. So we've got what's called an intake team. And we actually had 2 of them for a long time. Patients come in, they come into the reception area, they get this brief 5-question triage. We don't put meds in. We ask them about allergies, but we don't put them in the computer. We ask them their chief complaint, we do a set of vital signs, we get a pain scale on them, we assign their ESI level, and that's it. And then they're seen immediately by a doc. They go to radiology, if they need an x-ray, and lab, which are about 5 or 10 feet away. So they're all right in that front end. And then they go right back to the waiting room, but the waiting room is actually just roped off. So we have half of our waiting room roped off, and it's a results waiting room. And so now patients are just waiting for stuff to come back instead of waiting on a provider. So we've basically cut out all of that stuff. So the registration can happen there. The med reconciliation can happen in that results waiting area. Anything can happen there. And there's also internal versions of this. This is an internal results waiting area that we have. And again, there's a nurse there all the time. So instead of the nurse going in and out of the room, wandering back to the nurse's station and checking on this and checking on that, we have a whole group of patients, 9 patients, who the nurse is with them the whole entire time. Yeah, they're sitting next to strangers, but wouldn't they be doing that anyway in the waiting room? They'd be doing that in the waiting room with strangers that they don't know and conditions that we don't know about. So these are all known patients now who we've assessed and we've determined are safe to remain in this level of care. And then just the last couple things. Again, that was as much as I can give you in an hour in terms of perfecting your emergency department. But the biggest thing here, and this is why I love lean, is because you really have to develop your organization and change it into a learning organization. So you've got to have the leadership and the change capacity to get all this stuff done. And this is one of my favorite quotes of all time, and by Machiavelli, and it says, "It must be considered that there's nothing more difficult to carry out, nor more doubtful of success, nor more dangerous to handle than to initiate a new order of things. For the reformer has enemies in all those who profit by the old order, and only lukewarm defenders and those who would profit by the new order. This lukewarmness arising partly from the incredulity of mankind, who does not truly believe in anything new until they've had the experience of it." And I've worked with, again, many EDs, and this seems to be the #1 issue, is that people benefit from the old way, and they kind of see the new way, but they can't share in your vision because they haven't had the experience of what that new process can look like. So the way you get them to see your vision and to experience new things is you create this community of scientists. So you get your leadership and you get this vision of how you want your ED to function. You develop this culture where experimentation, the improvement cycles, rapid cycle testing, where that becomes a normal thing. Like, what are we going to change today? What are we going to experiment with? What are we going to learn? That's supported all the way up your organization. And in countries that have nationalized systems that are supported all the way through the system. The UK is doing a great job of this with deploying lean. Canada is doing a great job too with targeting these now response times for CTAS 4 and 5 patients, and England's doing the same thing, and Australia's will be following. So rapid cycle testing is a way where you come up with a crazy idea, you show up, you blow up the old way, and then you put it back together the same day. You say, hey, I'm going to look at this, we're going to all design something new, and we're going to show up on Friday, we're going to try it for a few hours, and then we're going to go back, look at it, and see if it was an improvement. The whole Deming way, right, which is do something different, then learn if it was an improvement or not. Kaizen, you guys may have heard of Kaizen or rapid improvement events. These are 3 to 5 day events where literally you blow it up and you never go back. And I can tell you I've done them both ways, and there's different scenarios that are right for different approaches. Kaizen events are great, or rapid improvement events where you just blow it up for mature organizations or organizations that are really interested in change and are going to go at it full-hearted. Rapid cycle testing is good if you don't quite know the answer or you've got a lot of resistance that you're trying to overcome. So allowing them to see the future is a great way to help get there. So just in summary, lean queuing theory, again, I don't care what methodology you use, but you have to understand the concepts. And the most important thing that if I've told you anything that's important today, it's that you've got to have a system for improvement. You can't fix something if there's not a system to fix. That goes with performance improvement as well. So you've got to have a systematic approach, and my particular philosophy and my tools are grounded in lean and queuing theory and the theory of constraints. We didn't have time to talk about that today, but we've kind of touched on bits and pieces of it. And then perfecting ED operations requires real commitment all the way up through your organization, focusing on these 3 key intervals, which is the disposition to departure, which is the most important interval in the ED, the door to dock interval, and then that interval in between, which is the dock to the disposition. So again, there's some great reading out there. I have a book coming out in just a couple weeks that's available on Amazon. It's got all these principles in it, and it's got best practices. It's about 400 pages, so it's meant to be a textbook. It should kind of provide, if this information intrigues you, it should kind of drive you in that direction. If you're interested in lean healthcare, Mark Graben has got a really good book called Lean Hospitals. There are some other great, IHI's got a white paper that you can download from the website called Going Lean in Healthcare. It's about a 20-page, really great, one of my favorite articles. So, and again, all of this is applicable across all different kinds of organizations, not just the emergency department. So if you're not from the emergency department, but you're just kind of interested in this stuff, you can take this and you can apply it to anything. So thank you very much, and I think our hour's up. Happy to hang around if there are any questions, or I'll feel free to kind of hang around a few minutes. But thank you very much.